master's in business administration. She has a BSc honors in reproductive health and family sciences. She has a national diploma in forensic science and crime investigation, majoring in medical law. And she, in the past, has been a nurse administrator, a midwife, and has done general nursing. So welcome, Sister Sipho. That's quite a lot of credentials. Her experience spans more than 3.5 decades, rising through nursing and managerial positions. And she still yearns more to assist the betterment of livelihoods. She is currently working at Ongwediva Medipark as the Quality Assurance Manager, spearheading the ISO 9001:2015 Quality Management System certification process, after some Namibian Standards Institution audits. She is also passionate about quality management systems in healthcare, and she plays a pivotal role as a technical expert QMS auditor for the Standards Association of Zimbabwe, as a visiting lecturer in the Post-Basic School of Nursing in Harare, Zimbabwe, and she also does charity work and skills empowerment for the vulnerable. She strongly believes everyone can reach their greatest potential with the appropriate support. So welcome, Sister Sipho, and I'm going to hand the floor over to you.
Thank you so much, Jackie, for the introduction and for having me on the floor again. Good evening, everyone. I hope this finds you well, wherever you are. Right, I'll take it away. Our topic tonight is on the ethical integration of healthcare information management system. And we are going to discuss the information management systems, linking it to the previous 3 last week's lectures we had on HIV management. And we'll also look at medical legal records keeping and information sharing, and it must be in accordance with the data laws, compliance, and adherence to all policies that we have on hand. And we should always be looking at the red ribbon, not only on the 1st of December, but every day, because in our midst, we have people who are living with HIV and AIDS, or have been affected by its glaring effects on livelihoods. My presentation is going to be in this outline that I'm posting on the screen at the moment. Oh, sorry, I went too fast. So I'll take that again so that you can see what we are going to look at. It's going to be a focused group discussion and not a lecture per se. We are just reminding ourselves of what it is that we need to improve on, what we are doing every day, because together as a team, we can always cross-fertilize each other. I'm not speaking about anything that any one of us does not know. And the importance of proper record keeping in HIV management is followed up by all our clinicians, and we need to continually improve in a holistic manner, and everything that we do must be patient-centered and not compare patient A to patient C or patient Z, because everyone is unique in their own right, and we need to dance to their tune as they grapple with the HIV and AIDS, including STIs that they are battling with. I've posted a disclaimer then. In one of my slides, you're going to see, sorry, it's going too fast for me, sorry, excuse me. You're going to see an illustration showing a suggestion for improvements, and the illustrations that I've put there are branded, and I am not conflicting interest with those. It is just samples that I could easily pick at hand so that we can look at it together. I'm just a proponent for ensuring that the public has access to information, and so that the vulnerable can play their role in self-health care. We need not to be paternalistic. Everyone who's suffering an ailment has a very pivotal role to play in their well-being, and we'll look at that tonight. By way of introduction, we all know that HIV and AIDS, including STIs, have been a global public health concern, and more than 30 million deaths were reported. And more than 70% of 35 million living with HIV and AIDS are living in sub-Saharan Africa, where you and I are at the moment, except for our colleagues who are beyond the borders and across the oceans. And currently, there's limited availability in some communities of ARVs because they do not cure, but they only slow the progression of the disease. And during HIV care, treatment, and related research, especially in preventive measures and the clinical trials that are currently running on vaccination, we require to uphold stringent ethical guidelines because we are dealing with the vulnerable, and we are not using human beings as guinea pigs, but they are affected and they voluntarily agreed to be on the clinical trials after explanation of all the do's and don'ts and the benefits and what could go wrong during any therapy. And ethics and professional practice are cornerstones in quality health care that we provide every day. And professional codes of conduct are always existing for time immemorial, and they will always be there. And all of us have legal duties. And ethics and legal duties are interrelated. We cannot separate them. And so we have responsibility that are expected of us by the community that gives their lives into our custody. And we provide the basic of moral standards during care, not just HIV, because HIV could be underlying with other comorbidities, or it can be on its own. And we are expected to do so much by the patients that we look after and the staff that we work with or supervise. And I would like to pose this question: how do we care for each other? We are not only talking about the patients that come to our clinics or are bedridden in the hospitals dotted around the world, but one day you and I will need to look after a colleague. And do we still remain ethical when we are looking after colleagues also? The ethical principles that we're looking at are four-pronged, and we'll start with autonomy, which is a fundamental right that any individual has, and everyone has a right to determine their choices, and we should respect what it is they want done for them. But this can come with dilemmas, doesn't it? And if it comes with dilemmas, how do we handle them? What if their informed decision causes harm, especially when they are compass mentors, they are quite wide awake and they are not affected by anything, but still the decision that they take, either to continue being reviewed by doctors or continue medication or discontinue because they are tired of side effects, what do we do to help them carry on? And what do we do when a patient is incompetent to take such a decision? Do we get paternalistic, or we say we are gluing onto autonomy and not do anything? And how autonomous are the children? And the second one is beneficency. Health professionals do good to patients and no harm, and we all took oath to observe this. We always are obliged to be positive in everything that we do and not in negation. Not without criticism to avert any paternalism, because at times we have to take the leading role in an individual's treatment, but without disregarding how they feel about everything going around them. What is good for the patient is not always good for the healthcare practitioners. And we must remember, discomfort or pain is what the patients are telling us and not what we perceive they are going through. And we can achieve more and do no harm if we lend a listening ear all the time. The third part is non-maleficency. We do no harm and we uphold the sanctity of life at all costs. We consider the physical and psychological pain that our clients are exposed to, or our patients or the affected communities. For example, when we are setting up an IV line, there's some pain that a patient will have to bear, or when we are taking a sample of blood to test for anything, including HIV. And surgery, of course, we inflict cuts on the patients, and how then do we manage the pain, especially when they're HIV positive or presumed HIV positive? Do we withhold doing surgery because of their status? And there are so many other invasive procedures. May you please mute your mics if you're not presenting. We'll let everyone play an active role at the end of the session to ask as much as we can. And it's going to be a focal group discussion. Like I said, I'm just team leading. We learn from each other all the time. Thank you. I've spoken about HIV testing, and non-maleficence always mirrors the second ethical principle that we spoke about. And lastly, we're going to be looking at justice, not just its legality, but equality and the fairness that goes with it and in bioethics. And every action that we take must be equal. No human being is better than the other, and we shouldn't give preferential treatment to A and not to X, Y, or Z person. And we must ensure that we take into account the economics that go with healthcare, and we must achieve equality. Even those that are not moneyed are still human and they need to be cared for, and governments have set up a fund to look for everyone. We all pay as you earn, it's month end, and people, you'll hear them at times going like, when you go to a state hospital, it's free for all. But remember, every human being who's contributing to the GDP of any country is paying taxes, and we look after our own that way. So let's preserve what is in our pockets and not abuse it, because we don't want our coffers to run dry. And consider equitable socio-economic factors that affect everyone as we render quality healthcare. No matter a patient is in a private setting or a government institution or in a rural health center, everyone deserves the best of quality when they are under the weather. Now, we're going to be looking at the ethical issues that are surrounding the management of HIV, including STIs, because we cannot separate STIs from HIV and AIDS, especially for the communities that are sexually active. Stigma is a problem in healthcare. And why are people living with HIV stigmatized? That's a question we all need to answer at the end of this. And the majority at high risk who have tested HIV positive do it anonymously. They are not freely talking about it, even to family members, because of fear of being stigmatized or being finger pointed. They are the wrongdoer. And let's remember, we don't always know how somebody got HIV, and that may complicate to AIDS. It may not be their fault, or they may have done it thinking they are having fun and they end up in problems. When they are now in a confirmed HIV positivity status, we are here to help them and not discriminate against them. And some people strongly feel, even through support groups, that we shouldn't be reporting on their status using their names, but using pseudonyms or non-diplomas, so that at least they don't lose their decency and privacy shouldn't be breached. Non-disclosure to HIV, why do people do not disclose their sex partners or people who are sharing needles? We don't want to call them drug abusers, because as health practitioners, we want to control them so that they come out of that habit. Whilst they are doing this unsocial ill, they don't forewarn the others. I think I am HIV positive, or I tested HIV positive, especially when they're sharing sharp instruments like that with others who are HIV negative or whose status remains unknown until proven otherwise. When it comes to disclosure, I put up that puzzle for us to look at. For somebody to require, we need those 4 pieces of the puzzle to knit together. We need an understanding somebody to talk to, somebody who's competent to help the person, and the person who needs the help must voluntarily do so. Only then can they disclose, when they've garnered trust, that whatever we are discussing beyond closed doors is not going to leak into the public forum and go into ears that are not supposed to hear whatever is being discussed for medical management. During the advent and the scare that we got on HIV, a lot of research was done, and it generated a lot of attention worldwide. And it brought real life or real living to people who'd lost hope, because some people then got better and they continued with their activities of daily living. But research also, some people think on the other side, is it always beneficial, or we are giving false hope to the needy? And are we underestimating the risk levels? And when recruiting healthcare practitioners to do this research, or we are looking at healthy participants to the study, are they really certain about what's going to be the outcome of the treatment that they are now undertaking? And currently, little is known about the potential of ethical problems in many ways that informed consent for HIV cure research is described, and how do the potential participants feel about it? In the early phases, consent forms were analyzed to assess how the study was aimed to deliver, the potential risks that the participants were exposed to, and the benefits that were presented during studies. And 13 consent forms were looked at from a very wide range of a group under clinical studies. And they represented categories of people who had consented to undergo the cure research. And 11 of these were interventional, and there was genetic transfer. Some got vaccination, which was intensified, and treatment was interrupted in some cases. And there was some latency that could have been reversed. And 2 of them were just observational. And consent forms were then coded in 7 categories. And it was all designed to ensure that desired outcomes were reached, and certain criterion were set. And we still continued to look at the presentation of the benefits against the risk. And in medicine, we always give medication so that we get most out of it and not the risks per se. Although there is no treatment that goes without any risks that people are exposed to. And there's potential return to the research results that have been put out there. We may need to go back and relook depending on future findings, because research is ongoing. And it must always demonstrate variations and deficiencies that we improve on, so that we continually work on saving humanity. And challenges cannot be forgone. And we need to be very specific and consistent, especially in the language that we use to describe the aims of the study, the risks that people are exposed to, the benefits that the participants can get, and the results that are expected by the healthcare practitioners. And informed consent for HIV research presents the opportunity for us to apply more relevant existing guidance that measures the effectiveness of the applications and development that is standardized, the best practices and policies for consent forms and the processes during audits. After we are done, please take time to look at those articles that have just flighted now. They are very interesting, and we can read more about getting informed consent from our patients. And it's not only consent forms for HIV management, it could be for other medical interventions, investigations, including surgery. The disabled, how well catered are they? Do we always look at the downside? They are already physically or mentally disabled. When they are HIV positive, do we consider the barriers that they are facing? Do we lend them a listening ear? And are our hospitals user-friendly for them? How do we render the services to these patients? Is there enough knowledge amongst us as caregivers? Can they access the facilities, especially if they have limb problems? How are they going to walk from their household to the next health center? Are we still going out into the community to bring it home to the people so they don't need to walk all the way to a hospital they cannot reach at any time? Is there enough demand for services? Are there continuous monitoring and evaluations programs that are happening throughout all our ministries of health and other humanity services in the world? Do they get enough emotional support? And most of them have complained that they lack emotional support, and we always want to treat them maybe like special people, call them the vulnerable, and they don't like to be called that. They want to be called by their names and respected for who they are. They did not apply or ask to be in such a predicament. And we have added in responsibility as caregivers, but they also have responsibilities, especially if they are adults. They are disabled, but you'll find people taking children to their household so that they are looked after by the disabled. They will have to be nurturing those children, yet they have inherent problems they have to be catering for themselves, and they can't say no at times. And it makes it very difficult for them if they are caregivers and they have to be taking medications, or they are looking after children who are HIV positive. And you know, children don't like to take medications because they think it's bitter, or we are punishing them for reasons that they can't understand. And we continue looking at disabilities. Those living with disabilities often feel they're excluded from programs and education and prevention and support services that are available to the able-bodied ones. And assumptions in some studies that were done were that healthcare practitioners think they are not sexually active. And remember, we call them men or women, and they also have reproductive organs, and they have free flow of their reproductive hormonal capacities. And what happens to them when they feel they want to copulate, or they want to be more cozier with a preferred somebody that they want to be next to? Do we engage them to avoid risky behavior, especially those that use habit-forming drugs and other unsocial vices? Are the healthcare practitioners knowledgeable when they render sexual and reproductive health? And what do we need to look at? We need to always be informing them. My apologies, I'm just taking a sip of water. Are we effectively informing them, or are we misguiding them? Are we stigmatizing them because they are living with disabilities? And services that are offered in all healthcare centers, are they accessible? Remember, the principles of primary healthcare, affordability, accessibility, and all the A's that go with it. Does this apply to those living with disabilities? And are we providing the necessary information and education and communication platforms that will better inform them to make informed decisions? Why is it that in hospitals, we can't sign language when those that are mute and deaf cannot hear what we are saying? They can't have that voice because of their inherent, maybe congenital abnormalities or injuries led them to be like that. That's food for thought. All of us, let's look back at the institutions we've come from after a day's hard work. Are there sign languages posted around strategic areas so that when somebody who's deaf and mute can talk to us when they come to our facilities? Is Braille available on the IEC material? Do we have audios, little radios that can play back the health education for them to listen at their earliest convenience? Do we use plain language, or we get very scientific when we are talking to our clients? That's where the disclaimer is coming from. And 2 days ago, we celebrated the World Pharmacist Day. We appreciate our pharmacists. Without them, we can't be curing any of the medical ailments that we are facing as a populace living on Earth. And their theme this year is pharmacy strengthening health systems. I've posed a question there. I've put 3 samples of packaging with Braille. I was very impressed at one of the CPD sessions that I went to when a pharmaceutical company was introducing that anti-inflammatory product that you are seeing named Gout Seal 40. There's Braille in there. The blind can read that and comply with their treatment. The center one is effervescent paracetamol. That is very basic for fever management and pain control. And in the cosmetic world, the perfumeries have gone a further step to have Braille. Are any of our retroviral medicaments that are available labeled in Braille too? Even all our computers, our cell phones, the figure 5 has a raising to guide the blind. We need to do this. I'm challenging the pharmacists that are in the house to see how they can continually improve labeling medication for those that are disabled. So when they are alone, they are not stranded. They can still feel and read and not underdose or overdose themselves. Tanzania ran a study. It's quite recent, 2 years ago, and it was led by Bajaria and colleagues. And they looked at the distance that the people had to be covering to get to caregivers when they are disabled, and the linkage of our OVCs whilst they are having care. And what did they find? Despite all the counseling and testing services that were being run, Tanzania linked the points and diagnosis to these centers that it was very low. Why was uptake very low? Inaccessibility. And further studies also looked at the barriers that we faced. And in some instances, not every healthcare practitioner was well trained to cater for them when they were suffering from HIV. And there was a poor health referral system that also was a drawback. And it is really sad because we then lose patients when they relapse because of complacency or they give up on life. There was an article that I saw on suicide, but I didn't want to make it sad. So I didn't go into details to screenshot this, because remember, we said we are preserving lives and we don't want to be seen like we are enhancing it, although we are living with the problem. And currently in Namibia, we've had a turmoil in the last 17 months where more than 500 people committed suicide, maybe because as healthcare practitioners, we were not listening fully to them, or it's their families that were not listening to their worries, and maybe they were tired of life because nobody seemed to care. Employees and employers have a mutual responsibility to prevent discrimination in the workplace. What do we do? How do we react when a colleague opens to us, when they disclose they are HIV positive and they want to be excused to go for a top-up of their medications, or they are due for blood work? Oh, this one is always sick. This one is always absent. She's self-pitying. She's attention-seeking. If that falls on a colleague's ear, they withdraw, and you may never know why they are so absent from work is because they spent 8 or 12 hours on duty, but colleagues in a health setting are not listening to them. So what do? Let's not leave each other stranded. And all people that are living with HIV and AIDS and STIs that are being treated have liberties and autonomy, and we need to ensure that everybody has freedom of movement to go from point A to point B. And I must commend Namibia because this is stipulated in all the documents that I'm going to share in this presentation, including the Constitution of Namibia says there should be freedom of movement. If one person moves from one region or one town to the other, they must still get health care because they walk around with their health passport. And it's referenced in the Namibian Constitution's fundamental freedoms and rights that are under Articles 5 to 25. And when we look at these articles, let's marry them to what is applicable in healthcare delivery. And confidentiality is really critical when people voluntarily come for counseling and testing and they want to know their HIV status. And we should be encouraging them and not look down upon them. Neither should we discourage them and discriminate. Whilst we are doing our work, are we protecting the patient's medical legal documents from the time that they are admitted until they are discharged? They go home, or maybe if they can't recover from their illness, they may be discharged the other way to the morgue. Their documents still remain protected. And are we doing this? And I posed a question there in red. What more can we do that the patients or the public that brings their loved ones to us still remain trustful in all that we do? And we can improve this as a team. We don't bring each other down. Together, we can make it. Look at how patients' information is exposed. Even our own information, when we are employed, we fill in those forms freely and we are happy we've been offered a job. And look at that cycle. The center is healthcare information when a patient is coming into hospital. And that figuring that you see on top there is us, the healthcare practitioners. We have a lot of information that we hold. We have prescriptions from doctors that we should hold in privacy. We have investigation results, laboratory results, we get X-ray results, we get messages sent to phones. We are living in a digital world. We not like us in the old WhatsApp group where you waited for a printed out lab result. Before it's printed, the doctor already knows the printed out one will come later and action has already been taken. What happens to all the information that is in admission sections of the hospital? What happens to all the data that has been captured by all the laboratories that are helping us make decisions that are informed when we get the result? And also in radiology, what is happening to all that data? Is it safe? If there are IT experts in our midst, I would also want to challenge them to assist us as we look after the patient. And when we take samples from patients, remember we store them until such a time. And what are we doing with the human tissue is still information that is coming from a human being, and it must be held with utmost care and respect. And when we medicate patients, give other forms of treatment, how accurate are we medico-legally documenting, including safe storage of everything that we are holding in custody? Are we accurately dosing our patients? Are we giving it on time? Is our documentation well legible? And are we storing the healthcare information safely, including the medications, without exposure to the adverse effects of weather, either rain, water, or this sweltering sun of the summer? And are we concerned about treatment compliance? How is the supply chain when HIV positive patients run out of medication? Can they go to the nearest health center and get the brand that they always know so that they don't get confused? And can they afford to remain on treatment? And we also need to remember during this care, we are closely monitoring and evaluating treatment efficacy after all the informative laboratory results that we run. And we must always ensure that treatment that we give to the patient is safe. And this is when we commend the pharmaceutical companies. They only release a product onto the market when it's gone through rigorous testing that it does not harm human beings, but improve their lives. How are lost and damaged health passports or cards replaced? Do we have any backup in our areas? And remember, all that history that is lost, where do we start from? Say somebody moves to an area where they are not even known. How are they better managed and we don't regress? Because we want people to improve and not to get worse. What happens if there's loss of continuity in HIV management? And how safe are all the hospital or clinical ministries of health electronic database management system? Yes, we are living in the e-world, G5 or 5G, they call it. And what happens to the good old files? Do we leave them flying around so everybody can read what's happening to a patient when they've nothing to do with their management? And I like the Access to Information Act that was released last year in Namibia. It was assented by the parliament through the presidency in Namibia to allow every human being living in Namibia to have access to information, including health information, which is also espoused in most Ministry of Health patients' charters. And do we talk about adversities when they happen? And do we report them? When medical errors happen, when an overdose or a wrong medication is given, do we report to the regulatory bodies that govern our practices to protect the patients? And November is coming soon. Every November 7 to 13, it's commemoration of patient safety in hospitals when they are on treatment. And do we wait for November to keep patients safe, or it should be a daily piece of bread? And follow-up should always be done, not to say your appointment is next week, come next week. If I'm feeling unwell, I should be able to go back to my healthcare practitioners that sustain my life up to today, for example. And our support systems should be very robust, and we should always be compliant. And we all have a duty to forewarn others if at all we have noted that there is exposure danger to the unknowing colleagues or family members. And when clients or family members then disclose their status without getting informed consent, what do we do? And at times, some people keep their status away from their sexual partners because they don't want to lose that person that they so love. And what criteria do we follow? Those that are positive and in question, are thoroughly counseled and need partner notification. If you talk to them, they'll understand the importance why they should protect their loved one by letting them know. So they also participate in helping them eat properly, exercise, rest, take them to the doctor, take them to the clinic, assist in activities of daily living. People tend to do better when they know what's wrong with you, and you always get the help that you need as a patient or as a healthcare practitioner. And what risks do we have when people do not disclose and yet we know the infection is existing? We must be reasonable in all the advances that we make, and it is what we call shared confidentiality to protect others. And follow-ups are really necessary. Support groups are really key. And we still need to report. This database assists ministries of health make national and even regional decisions to assist all ministries around the world to look at the disease burden and then report to the World Health Organization and the CDC. And we need to always ensure that we protect the patients. They don't feel vulnerable and so exposed that patient so-and-so that I'm sharing a room with knows that I'm HIV positive. Maybe they are even uncomfortable to share the fruit that my visitors brought, or share the same shower, or sit on the same toilet pot if we are sharing a room in a hospital or at home or in any social area. And what medical legal documentation principles do we also need to look at? And are we always strictly adhering to them? I colored it red as a reminder. Let's protect the information on any piece of sheet that carries vital medical information about somebody, be it HIV or any other diagnosis. We need to protect our patients. And Namibia is currently going through revision of a draft bill. It has gone through rigorous revisions. Now the third stint happened early this year in March. And there's going to be a data protection act that will ensure that everyone across the spans of economy, health, industry, and commerce, whatever information that you hold, it must be kept private. Even if it is a cell phone network provider with my details, you don't give it to the next person unless there's a legal implication where somebody has been involved in a crime, or their phone was picked and they are a suspect at a crime scene. Only then can this be used to track them. And South Africa has what they call POPI, Protection of Personal Information. It's about 8 years old, and all these things, it's a decade old now. Sorry, I'm a bit behind, but it is good when countries come up with such protection bills, and it gives the population safety zones to hide in. Like I said, the third Namibia Data Laws and Cybersecurity Conference was held in Windhoek early this year at the end of March. And what came out glaringly in that conference was this diagram. The person at the center, for purposes of our discussion tonight, we'll call them a patient, but you can put any person who is a client in any industry and commerce. But for medical purposes, I decided to put the center person as a patient. And what do public policies say about protecting their information? We are always collecting data. It is good that we collect data in hospitals, but what then do we do with the data to improve livelihoods? Do we have systems in place to ensure that the data that we've collected is not under any threat or destruction? Because we'll still need to refer it. People are born in families, and that information may help the next generation in whichever family we are looking at. And at that conference, can you see the weakest link in this chain? We were told it's people. For our purposes, I put healthcare workers. As healthcare workers, what are we doing when we hold vital information that tells us this Mr. X is HIV positive, this one is a disordered couple, this one is a positive mother, but she wants to breastfeed her child. This one is a beautiful, reproductive, willing woman who's newlywed. She wants to copulate and have babies. Do we stop them from having babies because they are HIV positive when there are so many options that people can go on? So as a people, as healthcare practitioners, let's be wary of the role that we play in weakening any link. My advice is let's keep tightening the chain link so that it doesn't break and we win everybody's heart and protect each other. We need to continually improve the holistic quality care that is protective and patient-centric all the time. Are we still doing outreaches and offering health education each time we meet a client, be it HIV or any comorbidity or any simple illness like the flus that have just rippled us after COVID went under? Are employers considerate when it comes to accommodating staff that are infected, or they are affected? They are always late. Every day they clock late because they had to bath a loved one at home, cook for them before they go to work. And they come very tired the next morning and they don't perform. Do we ask, is anything the matter? Can they disclose? How is our attitude? How are our management styles if we are in leadership? How do we then help them comply with treatment if they are infected? Do we make sure there are health breaks? Because most medication must be taken anti-sebum or post-sebum before or after a meal. Or you roll it. If you're on duty for 8 hours, work, no health breaks. Yet all the labor acts in the world allow for health breaks because we need to feed the body and the brain that is working and thinking respectively. And when we are looking at national levels, local level, be it regional and global levels, are we doing enough to clear the burden of HIV and AIDS? Have we considered the rights and the needs of those people that are living with disabilities, and we design legislation that fits them? Is everybody well funded? For instance, in Zimbabwe, there is what is called an AIDS levy. Every worker contributes a percentage of their earnings towards that through the National AIDS Council. And that is an up for Zimbabwe because it made availability of resources for those that are infected and affected to carry on with life. Such policies are very welcome. And we must uphold and not see them being grounded. Let's continually improve on them. And are we advocates to create improved dialogue between us and our clients, be it an able-bodied person or those living with disability? And do we discuss their concerns in an ethical manner each time we interact face-to-face? And there's need for us to focus and take more cognizance of what disability-led households are going through and improve their access to HIV management services. Let us remember to continuously be ethical in all our dealings, and we must highlight this every day. It must be singing in our heads as we are walking about the corridors, going about from point A to point B in a health setting. Is what I am doing ethical to protect the next person that I'm looking after? Am I being ethical? Am I giving all the information to my colleague who's going to take over management of that patient? And let's take part in researches. R&D only improves how we look at things that pertain to healthcare. How long do we monitor and support research and the participants? Cohort studies continue. It's not that people who were participants in a clinical trial are left like that. They are followed up for as long as they are walking on this earth. And the long-term toxicities are dealt with diligently, under scrutiny, under the microscope of the laboratory to guide our dear doctors and other specialists who have specialized in HIV management. And we need to protect the participants and the researchers too, because they don't mean any harm, but they are doing good. These are all the references that I looked at. You can look at them at your earliest convenience. And this brings us to the end of our discussion. And because I'm Namibia, I know Jackie said I'm Zimbabwean, but I'm Zimnam. And I looked at the handful of statutes that are available in Namibia. And I think the world over, we have a lot of statutes that govern healthcare, and let's comply with mandatory statutory regulations because they guide us as we work daily and deliver the healthcare that we said we are going to do from the day that we took oath. I thank you for listening for tonight. And we come to the end of my team leading, and we now open the house for questions and answers. And everybody in the house must feel free to contribute towards this. And I hope I brought to memory and reminded us what it is that we are supposed to do as the medical fraternity. I thank you.
Thank you, Sipho. That was a brilliant presentation. There are a couple of questions in the chat, but one of the things I wanted to ask, or one of the things I wanted to mention, yesterday was World Contraception Day. And as Abacare, we went out to a clinic in a high density area close to Harare. And sorry, they must me stop my video. So we went out to the this high density clinic, and I think that in order for healthcare workers to be able to deliver the ideal service, somebody has to look after the healthcare workers. There were far too many patients, not enough staff. The pharmacy had, the only antibiotic they had was cotrimoxazole. The antihypertensives, atenolol, empty. Nifedipine, empty. ACE inhibitors, empty. They had some hydrochlorothiazide, metformin, empty. So one of the things, the law states and ethics state that we have to deliver a certain level of care. But as we hemorrhage nurses and doctors out of Zimbabwe, going to Australia and the UK because they can't survive on the salaries here, where are the statutes that say that the funds must go to where they're supposed to go? Because while there may be a levy, it certainly wasn't going to the clinic that I visited yesterday. And one of the things, I might just share my screen if I can. Can you see the screen? So one of the things that's being looked at extensively over COVID is the burnout of medical practitioners, particularly those who try to follow the oath. And essentially, about 9% of healthcare workers are actually satisfied. 20% are severely depressed. 69% are depressed. And when you look at what would actually improve their lives, it's basically less workload, better work-life balance, and financial remuneration. And I also think that while we need to look at the ethics and the rights of patients, we also need to consider the ethics and the rights of healthcare workers. And I'd be interested to hear your thoughts on that.
Thank you, Jackie, for going out on that outreach yesterday. It is very worrying that government still let brain drain, especially after taxpayers have meted it out to look after the populace. I think we need more voice to be heard even in decision-making parliamentarian platforms to be heard. This is why each country has a Ministry of Health. Let's have bodies, those bodies that we subscribe to every year. There's the Nurses Association of Zimbabwe. There's the Medical and Dental Allied Professions Council. What is it that they are doing? Do we meet as stakeholders to see what the healthcare workers are going through? Listen to them. How can we improve their working conditions? The Labor Ministry must also come in and social services and look at all this. Every country has a public service commission, and there's no public service commission without the employees. And every government is the biggest employer in any nation. And worker burnout breeds poor care in any sphere. We're still in a hospital. A tired doctor, a tired nurse cannot give quality healthcare. I think as healthcare practitioners, let's get together and rally behind each other and let our voice be heard. As professionals, we can't only be taking up to the streets and putting our tools down, risking life to say we are on strike because we are burnt out, we are not getting enough. We need to be heard. The more we act together as a formidable force and not backbite each other, the better our working conditions will improve. If we speak with that strong one voice, I'm sure we'll be heard. And I remember in Zimbabwe, I used to sit on the Doctors Association for Human Rights Advisory Board, and we were thrashing out things like this. Lawyers Association for Human Rights, let's get together. The legal practitioners help us. The Association for Human Rights, also there's a Zimbabwean Human Rights, and every country has such bodies. We get together and see what we can do. You don't want to be looked after by a very tiredness because they have to make critical decisions looking after the patients and know when things are going wrong, they act and reverse, call colleagues, call for help, or give medication that can reverse anything that we need to be looking at. It is said if funding is then misused, we need strict auditing. We need to have it put on the platform to say so much was collected and it was banked, it has gotten so much interest, and how it was dispersed, what went to who, and what did we get from there, and how much is remaining in the coffers. Funding should be directed for whatever it is meant to do. You can't be going to an outreach without medication to do. Then where do those people go and get medication? It's so sad. It may be happening in Zimbabwe. It can be happening in another country. Remember, people who are put in power are to serve the people and not to be served. Let people not only be heard when it's time for that X on a voting day. Let's see the fruits of those representatives that we voted into office to do it for us. I think the more we hold hands together in the bodies that we subscribe to every year, I'm sure these things can be better, and you don't want to end up with mentally affected healthcare practitioners. It would be sad because it's us who are supposed to be cushioning the rest of the suffering populace. And stock management that is robust is critical. Why did we go to zero in the first place? No healthcare institution should go to zero. Where is R&D? We have up-and-coming young scientists all over our nations. Give them the tools to research and develop and make use of the flora and fauna that is there, that can be compressed into medications. Let's keep all the pharmaceutical companies running and not only rely on the first world. And there's a group of scientists from the AIBS, African Institute of Biomedical Science and Technology. They were looking at making medications that are customized to fit our genomics and not something that is made out there, not to disgrace anyone, but if it's homegrown, the better, and we have less complications. I don't know if anyone wants to say something more.
If anybody wants to say anything, just raise your hand. Going back to the chat, Dr. Tenda Gotcha has said, my take is challenges in ethical management of HIV affected and infected came when ethical principles moved. Sorry, my screen's frozen. Move from healthcare workers' side to include patients as rights enforced by the positive patients in various councils, trusts, and organizations. I think what he's saying there is that people talk about patient rights, and the rights of the patient have been totally focused on, but ethical principles have been taken away from healthcare workers, partly through understaffing and partly because it's now enforced by councils. Another comment is that on shared, Dr. Suzanne Malonga says, on shared confidentiality, we are not talking about infected children who got the virus from the mother and not informed of their status, but simply forced to take their medication without question. As a result, we are seeing a high number of children being infected because of experimental sexual encounters between youngsters. How do we go about curbing this dilemma?
Take that again, Jackie. There is a part that wasn't clear.
As a result, we are seeing a high number of children who have been infected because of experimental sexual encounters between youngsters. How do we go about curbing this dilemma?
It's children who've been infected when they were in utero. Did I hear you right?
I think I might ask if Dr. Susanna Malunga is on the call. Can you clarify the question?
Yes, thank you, Jackie and Sipho for that. Sipho, on shared confidentiality, we're not talking a lot about kids that are infected, yes, through the mothers. So as a result because of the kids not knowing their status, we're seeing a high number of where children as young as 13 to 15 are being infected with the virus because of experimental sexual encounters among themselves. Now, how do we go about when we're talking about shared confidentiality and children not knowing what their status are? So how do we curb this problem?
Oh, now I get the point. Thanks for that question, Dr. Susanna. So the teenagers are getting their first debut into sexual activity, and they are unaware that they were infected when they were born. I think we need to still bolster school health programs, talk to the children, and discourage them from being sexually active before they are ready to be adults and deal with the consequences. But also us as adults, I think I blame it on the parents. If you know pretty well that you were exposed as a mother or a father, and you then copulated, ended up being pregnant, and you are taking your ARVs, the child is also tested, and you get to know about the child's status. When they get to understand what's happening, they see you popping your pills, you tell them in a child language that they will understand so that they can get better, and then they don't then feel rejected, or I want to infect more, or I'll still experiment while what we are learning in biology. It still comes to us as adults by not disclosing, and it's very sad. And for instance, like when I was studying reproductive health and family sciences, I noted that a lot of young boys were not told that at some point they suffered testicular torsion, and they went late to hospital because they didn't want to be open to their parents. They would be blamed for being sexually active, for feeling pain down there, and the urologist could not save them. When those people get into men, they marry, they can't sire any children. It's because they were never told. It's only blamed on the woman who is not falling pregnant. When that relationship is disbanded, that woman gets pregnant by somebody else. So it's up to us as parents to tell our children the truth about our status. They should know. It is their legal right to know. And children behave better. I've seen in other settings where children are angry at their parents. It's you and dad who gave it to me. I didn't ask to be born. Now their counsel, the pediatricians come in, psychosocial support is rendered. They then become better. This experimenting at schools is still rife, and it's worrying because we end up with unwanted pregnancies, STIs still spread around. And one of my studies in reproductive health, it was at a certain high school where I wanted to understand if these teenagers understood what it is that can go wrong if they're exposed to HIV and AIDS and STIs. And some of them were just doing it for fun, just to prove what the biology book is saying. So the more we talk to our children in a friendly manner without threatening them and loving them, listen to them, do everything with them, they'll understand better. Children are better listeners than adults. And it's quite sad when our future generations are broken like that. And I hope we will win, and the Ministry of Health and Childcare must really be protecting. That's why it's called Ministry of Health and Childcare. We must go deeper and see what it is that we can do as a Ministry of Health and Childcare to make the children understand their health needs as they grow along the lifespan, because they are going to replace us when we are old and gone. I hope that helps, Dr. Susan. And it's quite sad when the children then give up and do it like that. And some parents even then leave this world and go into the yonder world. They die without even disclosing. And when these children discover, it's too late to then ask mom or dad so many questions. So it's us now as healthcare workers grappling with all the complications of non-disclosure from the word go. Disclosure is very important. It will save more lives or improve the quality of lives of those that are infected, not out of their own making, but in childbirth, like children you are dealing with.
Thank you,
And
Sipho.
programs should always be child-friendly, because the children were also complaining we are judgmental as healthcare workers. We say, how did you get it? Why are you sexually active? But you never know how that child got it. Some of them are molested or raped by family members or friends or people living in the community, and it's not reported. To protect the adults who are breadwinners, let's report all offenders. It's unfair for the livelihoods lives who's then put into disarray like that.
Thank you, Sipho. I think we've already gone 15 minutes over time. The last thing that we might want to actually talk about is how robust is data protection in sub-Saharan Africa? Are hard copies safe and retrievable? It is a nightmare to ask for one's old medical records in some public hospitals in the region. And I've certainly experienced this, where patients have gone to 4 different medical institutions, and I ask them to go and get their medical records, and they won't give them to them, or the photocopier is not working. So it's hard to get data. It's hard to get patient records, but one also has to ask how secure those patient records are. And what is the solution to that?
I hear you, Jackie, that's a headache that I always have, because we don't want to lose vital information, because it's connected to so many generations that are gone or generations to come. Like, for instance, in Zimbabwe, there is what is called the National Archives of Zimbabwe, and all medical records, be it from Home Affairs, they end up deposited in the National Archives. And archiving systems, I think, should be improved to ensure that these documents remain legible and they are not destroyed by water leakages or flooding in a building, or termites then attack a building that is not treated. Most institutions are looking at scanning those soft copies, hard copies, to make them soft copies and refile them so that data at least can be retrieved. After that data's law conference with the colleagues that I attended, the review in Windhoek, we went to a document processing unit, massive, and they haven't lost any documents. It's a huge building. If everybody does that, we are cocksure at any time you can retrieve whatever information, and we do it in batches to put it on the eBase, so that we have maybe warehouses of the hard copies, but we are also covered electronically. When you then have scanned documents, at any time you can then print when you need to guide your practice. Like Dr. Stone, when you want to look at the family history, there's a genetic problem, or there are comorbidities that are running in the family, it's easier for you to go that way. And it's quite sad when people hop around from one medical record in a hospital and nobody can know them. A trial that I did was to go to the labor ward where I was born 57 years ago, and I was impressed. I found that book. It's still there, and all the pages are intact. And if everybody does that, we are good to go, because when children now want to go to school or to university and they've lost their maybe birth certificates, they have to go back to the hospital where they were born if they were delivered at a hospital. If they were delivered at home, maybe the parents got a birth certificate for that child. But which registry office do you go to? Do you have to be going town to town? It should be so integrated that I don't have to go to like Kadoma. When I was born in Harare, at the press of a button, we should see the documents in a big e-database, and things can be printed there, because not everybody are forced to be going from town to town. They may not have somewhere to sleep. So then what happens? And everybody has a right to have these documents. And I hope all regional bodies will improve on archives. We have brilliant students that are in all our universities, like in Southern Africa, studying archiving. Let's take from the young men. If we learn from those young with brilliant ideas, I'm sure we will. It will take us time, but I'm sure we'll get somewhere, because you don't want to lose anybody's vital history. And I hope, Dr. Jackie, one day you'll get those medical records for the patients. And this thing of scanners are not working because machinery has not been replaced, I think the public works department must be doing its rounds and do their work and service machines, recalibrate them on time so that they are working and everybody can get what it is that they want at any given time. And not pay for printed documents, because it's a national document like an ID or a birth certificate. Why should I pay for it when taxpayers are already pumping out payee to support all that's happening? And one day I wish to be a minister of finance, because I understand these problems. Then maybe I'll be biased. A greater chunk may come to health or other sectors and education and so forth. But I appreciate those that are handling the big banks for us. But I think equitable distribution of all resources, be it monetary, human, material, must be well looked after, and people must not just be greedy to feed themselves, but look after the masses that voted them into power.
Thank you for that, Sipho. And if you ever do become Minister of Finance, I definitely vote for you.
Thank you. I've got a vote there.
But I think we should end it there. We've run a long time over time. Can people please fill in the attendance register? I'd like to extend gratitude to Intellectus Campus and to Avocare for funding this CME session. And unless there are any more questions, I will hand over to Belle to close.
Hi, Dr. Jackie. We lost you for a few seconds.
Okay, so I think we should end it there. Next week, we are quite excited about the a panel discussion that will happen. It will be based on whether we should be shifting certain patients from a TDF-based regimen to a TAF-LD regimen. And we will have regional people on the panel. Dr. Tadesi McConnell will be presenting the rationale behind switching from TDF to TAF. Dr. Agnes Katitsira from Zimbabwe will be on the panel discussion because he will do a presentation and then we will have questions. Dr. Enos Moyo will be on the panel, and we're excited to have Dr. Agri Mwemba from Zambia on the panel because he is a nephrologist with an interest in HIV. Professor Lloyd Mulenga is traveling, but if he gets back in time, he will join us on that panel. So next week, we look forward to a very interesting discussion as to the nephrotoxicity of TDF versus the metabolic problems of TAF. And I'd like to end it there. Thank you, everybody, for listening. And we will see you at 6:30 next Wednesday.
Hello.